I do think these support groups are incredibly important. And I think the voice that you have, you really should not underappreciate that. Just historically, there's been a sarcoma center here at UCLA since the late 70s, really, when my father came. So this is my father. And he was one of the pioneers of sarcoma surgery and therapy in general. One of the original people to pioneer limb salvage therapy. They used to amputate everybody for bone and soft tissue sarcomas. The Johnson Comprehensive Cancer Clinical Translational Sarcoma Program, that's kind of in its current iteration, was really put together, or the push to get that was from a patient, Kathy Goldring, who had leiomyosarcoma. And she wanted to kind of get it more organized in a multidisciplinary, patient-centric approach, and also to really push the research. And her efforts and her family's really provided a significant amount of resources and stuff like that. In fact, Bill Tapp, who was the lead author on that PGFR drug, who's now head of sarcoma medical oncology at Sloan Kettering, was a fellow here at the time. And I talked him, Kathy and I talked him into doing sarcoma, and he's since done very well, obviously. But that's the power of one patient. So don't underestimate that. So I'm not your typical surgeon. I am a professor of surgery. That's my formal appointment. I'm in a division of surgical oncology. I actually have a dual appointment in molecular and medical pharmacology. I am very much a sarcoma surgeon. That's basically all I do. You can't really have that kind of practice in the community. They're too rare. There's just not enough of them to do that. The only other places that that really exists are MD Anderson, somebody like me. There's MD Anderson, Sloan Kettering, and then in the foreign countries, there's usually one sarcoma center for the country. They're actually much better at funneling people to the sarcoma center than we are at the United States. And I'll talk about it, but there's lots of data showing that, the earlier you get to a multidisciplinary high-volume sarcoma center with a diagnosis of sarcoma, the better your outcomes are. It's not rocket science. And a lot of that data comes from these foreign countries with nationalized healthcare. So they just get it funneled, people get funneled quickly. So I was a surgical resident here, and I had the opportunity to train with my father. And more importantly, I started doing research at that time. We were required to do 2 years of research. I started doing research on sarcoma at that time. And then when I finished my residency, I went to Sloan Kettering to do my surgical oncology fellowship. The chairman of surgery there at the time was a gentleman named Murray Brennan, who also is very much interested in sarcoma and one of the pioneers as well. And we had the opportunity, and I'll talk about it, to use the large data sets from both institutions to answer some interesting questions that I wouldn't have been able to answer otherwise. And that collaboration was very important. I was actually, and I didn't even realize it at the time, I was the Kristen Ann Carr Surgical Oncology Fellow my second year, which apparently is of note now, which I didn't even know. I just found that out. But anyway, so I do think it is important when you're to obviously see somebody that is experienced in treating what you have. And I think that's particularly true with surgery because you do operate on different tumors very differently. And we'll talk about that in a second. Arun talked about this. And excuse me, I kind of pulled slides from various talks I've given over the years. But he talked about it. There's over 80 different subtypes of bone and soft tissue sarcomas, over 50 different subtypes of soft tissue sarcomas. There's subtypes within subtypes. Very complicated. They're all very different tumors. They historically were kind of lumped as one entity, but they're not. They're different malignancies. And even within a certain histology, as Arun pointed out, like leiomyosarcomas, there's different probably subtypes as well. And having an experienced pathologist is absolutely critical. And so we're fortunate here at UCLA to have 2 dedicated sarcoma pathologists with years of experience and large volumes, and that's really what it takes. And we're fortunate also, this is Scott Nelson, who likes to come to the operating room, which is also very helpful as well. So we are very lucky to have that. And we see around, in our weekly multidisciplinary sarcoma conference, we evaluate around 12 to 1,400 patients a year. And we review most of the outside pathology, and about 10% of the time, maybe a little higher, we disagree with the outside diagnosis. Sometimes we don't even think it's a sarcoma. So, I mean, that's an easy place to start, is to have your pathology reviewed by somebody that is experienced at this. So this is data from Sloan Kettering, just for soft tissue sarcoma. It's all over a 20-year period, all the soft tissue sarcomas that we're seeing at Sloan Kettering. And as you can see, leiomyosarcoma is the second or third most common histologic subtype of soft tissue sarcoma. MFH is actually a diagnosis that doesn't exist anymore. Very fluid, pathologic field. But overall, I think that's what I keep in my head. It's liposarcoma is the most common. Leiomyo is second or third most common histologic subtype by prevalence. Arun talked about this. There's a certain histology have a certain propensity for certain locations. I mean, they can occur anywhere in the body. But as he talked about, the most common site for a leiomyosarcoma is the viscera, uterus, GI. The second most common site is the retroperitoneum. And then after that, it's the extremity. But for a retroperitoneal sarcoma, it's the second most common diagnosis. In the extremity, it's the third. So you can't just think uterine leiomyosarcoma. I mean, it's all over the body. I think I mean, as a physician who treats sarcoma, that's how I think of it. I don't think of it as one specific entity. So these are very high-risk tumors, all comers. This is the survival for all of those 5,000 patients that presented to Sloan Kettering, regardless of grade, stage, whatever. The 5-year survival, all comers, was 50%. It's a high-risk tumor. There's a number of factors that predict outcome. This is an example of site and its impact on survival. Extremity tumors do better than abdominal or retroperitoneal tumors. The most important prognostic factor Dr. Singh talked about is grade. This is extremity sarcomas broken down by grade. Low-grade tumors have a much better survival than high-grade tumors. Second most important predictive factor in terms of predicting somebody's outcome or survival is the size. And this is extremity soft tissue, high-grade extremity soft tissue sarcomas broken down by size. Less than 5 centimeters, 5 to 10, greater than 10. So if you have a greater than 10 centimeter high-grade extremity sarcoma, your 5-year survival is about 40%. So big impact. Arun talked about this. People who treat this disease do not use the AJCC staging system. It just doesn't work. They don't go to lymph nodes. And there's lots of other factors that do predict the outcomes of these patients that aren't in that current system. So Dr. Brennan et al. Developed this prognostic model, or a nomogram, where it integrates the various prognostic factors for patients with sarcoma and it generates an individual patient outcome prediction. So size, depth, and grade are in the AGC staging system at the time when this is developed. Site, histology, and age are not. And then you can see leiomyo, let's see where it is here. Histology is here, and I'll show you how this works. But this nomogram was developed in 2002. It's really it was the first one. And the question was, does it work? Is it something that people can use? And to really prove that, you need to take a large data set, external data set, plug it in, and see if it could accurately predict the outcomes of those patients. Validate it, basically. And that's the first thing Dr. Brennan wanted from me, was to get a hold of the UCLA data set so he could plug it into his nomogram to see if it worked. So that's what we did. And I put this slide up, again, Leiomyosarcoma, basically the third most common histologic subtype. These are the data sets from each institution. This is the data set that was used to create the nomogram, and this is the validation data set. I put the percentages up. The numbers are essentially identical, and the percentages are very similar as well. Large, huge data sets where the percentages and the makeups of these, it's not like anything skewed. Anyway, to make a long story short, the nomogram was accurate at predicting the outcomes of these patients. It worked. And since that validation paper in 2004, the nomograms have exploded. They're all over the place. There's histology-specific nomograms for GIST, synovial sarcoma. There's site-specific nomograms. There's nomograms for almost every malignancy now outside of sarcoma. And so the number and use of them has really gone up. And the original one was driven from the sarcoma nomogram because the current staging system didn't really work for those patients. So is there a better way to do it? We were part of the validation of the original nomogram, and then this is a retroperitoneal nomogram. So this is a site-specific nomogram, a retroperitoneal sarcoma nomogram. And this was actually a very good nomogram. It was created from the data sets from here, MD Anderson, and the Milan Cancer Center in Italy, which is the major sarcoma center in Italy. Those three centers where we got all patients with primary retroperitoneal sarcomas, created the model, and then the data set from France was used to validate it. So this is the data set that was used to create it. Again, Leiomyosarcoma, right on the dot, third most common in the retroperitoneum. And I just wanted to show you how it works so you guys or other people can use it. This is a CT scan of one of my patients, a large right retroperitoneal mass. It was a biopsy. These are the kidneys here. It's the aorta, liver. It was biopsied and found to be a leiomyosarcoma. So here's how the nomogram works. 60-year-old male, 14-centimeter high-grade retroperitoneal leiomyosarcoma. You know, for me, it's a fairly typical patient. So it's quite simple. 60-year-old, they get 4 points. 14 centimeters, they get 40. High grade, they get 100 points. Leiomyosarcoma actually gets 20. It was not multifocal. I did a complete resection. Total points were 164. And then you just go down, draw the line down, which translates into a 7-year survival of 30%, predicted for that patient. So the difference between this and the current staging system is that it generates an individual patient outcome prediction rather than putting you into one of 4 stages that have a huge range. And the other thing, as Arun talked about, the utility of it is debated, but it gives you a feeling of how high risk you are. I think if I had that outcome prediction, I would strongly consider adjuvant therapies. if that was that. If it generated something that was much higher, I probably wouldn't. So it helps the patient and the physician strategize about which additional therapies to employ based on the risk profile of the tumor. So this went on to develop a leiomyosarcoma nomogram for uterine leiomyosarcoma. So as you can see, it snowballed. But I do think it's surprisingly useful. I was always wasn't sure at the time. And actually, Dr. Singh just showed me this the other day. I didn't even know about it, but this is an app. There's Sarculator. And it actually states it in there. It's based on our paper. I didn't even know about it. So they took the data for that was used to create the retroperitoneal nomogram, and you click on RPS is retroperitoneal sarcoma, and this is soft tissue sarcoma, and that's an extremity nomogram as well. And I think it's great. You know, the more people can learn and do things, and the access to the patients and the individuality of it is great. So anyway, that's something that's evolving rapidly, obviously, and all based on the work that has been done here to a certain degree. So I'm going to shift gears and actually talk about what I'm supposed to, the surgery. This is a kind of a generalized table in one of the surgery chapters I had to write for sarcoma. Very simplified table, but all in all, it's fairly accurate. So low-grade tumors get surgery. Alone, radiation is rarely, if ever, used for low-grade sarcomas. Intermediate grade, it's surgery and radiation therapy. Chemotherapy is rarely used for those groups. And for high-grade tumors, it's surgery, radiation therapy, and usually chemotherapy, depending on the situation. Or at least it should strongly be considered. In terms of surgery, it seems very straightforward, but there's a couple points I really want to bring out. It's critical for sarcoma patients to have thorough preoperative planning, to kind of scramble afterwards where you thought of a benign tumor and then find out that it was malignant sarcoma. It's better to have everything hashed out ahead of time, just like anything else. I mean, but I think it's particularly true in sarcoma. You obviously need to completely remove the tumor. I get asked this. In my opinion, you cannot debulk a sarcoma. It does no good. They bleed. They're back in a second. If you're going to take it out, you have to get it. Ideally, you'd like to have microscopically negative margins. That's an R0 resection. R1 resection is a microscopically positive resection. And R2 resection is when you cut through tumor. You obviously like to preserve maximal function. Biopsy site should be removed when you're resecting the specimen. That's really speaking to extremity sarcomas where the orthopedic surgeons were still doing operative biopsies. So if you make an incision to get a piece of that tumor, you have to take out that cut site, otherwise it'll recur right in the scar. And then if you have a positive margin at the time after resection, if you can, you should go back and get it. And that's, again, really more talking about extremity disease. It's hard to reoperate on the abdomen to chase a positive margin. But for the extremity, you can. And it happens to me, and it's painful, but it's best to get it. So I've given lots of talks about the surgical pitfalls. And I'm just going to kind of drill down on one for this group. And it's the most common pitfall that I see by outside general surgeons and primary care physicians as well. It's underestimating the malignant potential of the tumor. Basically, if they think the tumor is benign, they don't really work it up, they take it out, and oops, it's a sarcoma, right? The oops operation, you've probably heard of that. No more oops. Or a primary care physician says, it's a lipoma, just leave it alone, we'll wash it, and it grows. So, I mean, that's kind of the main big error that I see. And there's really three things to do that you can avoid this. You get imaging. It's amazing to me that people have these big tumors taken out and they've never even had a formal image. You get a tissue diagnosis preoperatively. Knowing what you're operating on is critical. Imaging, CT or MRI, it doesn't really matter. There's some data showing that extremity disease is better with a MRI. Certain histologies are imaged better with a CT. It's whatever the physician is most comfortable with, basically. You need a 3D picture of this tumor to see where it extends to and if there's any other sites. And then a tissue diagnosis. I do think this matters. You need a image-guided core needle biopsy. FNA is not big enough, doesn't get enough information. Our pathologists absolutely abhor them. You can tell it's got malignant cells, that's about it. An incisional biopsy, you get a lot of tissue, but it's very morbid for the patient. It's an operation. If the patient needs chemo or radiation prior to surgery, you can get wound infections where it opens and then they can't get treated. So there's some major risks that can derail somebody's therapy from having an operative biopsy. And the image-guided core needle biopsy, either ultrasound or CT guided, has really been fine-tuned, worked by a lot of our musculoskeletal radiologists here. And it's really the current standard of care everywhere. And I'll talk about this. And then once you have those, you need to have a multidisciplinary preoperative treatment plan outlined, particularly for sarcoma. So I just want to briefly talk about retroperitoneal. So yes, you need to biopsy these tumors. These tumors, they say, oh, you got to take it out anyway. Why are you biopsying it? They'll bleed or see the abdomen or all this stuff. No. The benefit of knowing what it is far outweighs those minuscule risks. I don't see seeding. I don't see bleeding. It can be done safely if it's done under guidance, and knowing what it is critical. They use a large caliber core, and we talked about it, FNA never, an operative biopsy for the retroperitoneal disease, again, never done. You don't want to have a surgery just to find out what you have. And this is from our pathologist. Tissue is the issue. And basically, with a core biopsy, there's enough tissue to do all the ancillary cytogenetic mutational analysis and even an electron microscopy that is required to give an accurate diagnosis. So it's big enough to get the answer, but it's not going to derail your therapy or incur major morbidity. So I'll give some examples of why this is important. This is a retroperitoneal tumor right in the middle. Radiologist said likely sarcoma. Could be. Could be a GIST, could be leiomyosarcoma, could be anything. It's right here, right in the middle. It was biopsied and found to be a diffuse B-cell lymphoma. The patient didn't need me to operate on him, ever. Went on to get the appropriate therapy. This is a large left retroperitoneal tumor. Biopsied. Found to be an extraskeletal Ewing sarcoma. That patient needs chemotherapy. Tumor shrank down, actually never had surgery. That's just the management of that tumor. If you'd operated on that tumor, you would have spread it all over the place. So again, getting the diagnosis. This is one on the right side, big tumor. Same thing, Ewing's. Treated appropriately. I think this patient ultimately had surgery, but the tumor shrank down beautifully. So you can see the importance of getting a diagnosis is critical in terms of managing these patients. So this push to rush without a diagnosis really makes no sense to me, and I push back extensively on that. So this is that patient I presented before for the nomogram, this right retroperitoneal mass. And the reason that the biopsy is critical in this case is that you can't see the inferior vena cava. Sometimes it's just compressed, right? But it was a leiomyosarcoma. Leiomyosarcoma arises from the vena cava. We know that. So if I'm the surgeon and it's a leiomyosarcoma and I can't see the vena cava, I'm going to do some preoperative planning where I'm going to have the vascular surgeon ready. So operatively, it helps me plan out the surgery as well. And so we took this out, did a vascular graph with a vascular surgeon who I have a long-standing relationship with, and he's actually written papers about how to do this, and we did it appropriately. And doing all that hinges on presenting these cases preoperatively in a multidisciplinary format. And this, in my opinion, is critical. This is our team here, our typical attendees at our weekly sarcoma conference. We have a pediatric medical oncologist, adult sarcoma medical oncologist, both of whom are speaking today. We have 2 dedicated sarcoma pathologists, Sandra's the nurse practitioner, basically for everybody. We have dedicated radiologists who present the imaging, dedicated sarcoma radiation therapist. It's not just something they treat sometimes. This is what he does. He does research on this. This is his deal. Orthopedic surgeons who take care of the bone and soft tissue, and there's a lot of overlap. We help each other out. The thoracic surgeons come. There's actually an additional one that comes, and Josh as well. It's very good. We didn't used to have the gynecologists come, but uterine leiomyosarcoma we see a fair amount of, and we're very fortunate that Josh does participate in that. So we talked about this. The imaging is reviewed in the context of that conference, and I actually learned things from our radiologists who point things out in the conference. Our pathologists will say things that are not in the report that says, yeah, I mean, this is really high grade, not just high grade. So that interplay is very important. We ask the question, should the patient have radiation before surgery or after? Chemotherapy before surgery or after? And then obviously thorough surgical planning as well. The other, as I talked about, there's lots of literature out there highlighting the importance of being taken care of at a multidisciplinary sarcoma center. This is a graph over volume. It's a little dated, but we evaluate anywhere from 12 to 1,400 patients a year in that weekly multidisciplinary sarcoma conference. And we operate on about 600 patients a year here at UCLA with a diagnosis of sarcoma. This is a very dated slide, but that conference is also it's an excellent environment to capture people for clinical trial. You wouldn't necessarily think of it, an imaging or radiation or imaging trial or radiation trial. We have a whole list of clinical trials available for sarcoma patients that you wouldn't really think of unless at that conference it gets brought up. So I've never actually asked the question how many people were captured by that conference, but it's a significant number for the appropriate trial. And that dovetails into the last topic that I will talk about, and it centers on that last question that was answered: how do you know the drug works? So we've done, as a surgeon, there's not much, we know how to do the surgery. Surgically, there's not a lot to answer. I've done, as a surgeon, I was a lead on several studies using PET imaging studies that were fairly important, using a new molecular imaging. And then this is one where I kind of pushed as well, in addition to supporting everybody else's clinical trials, including radiation therapy and the medical oncologist. But this is one that I had particular interest in. So, and I didn't have a lot of time to put this together, and it's still, it just closed. So what we did is this. So patient-derived orthotopic xenograft. It was a clinical trial for 1 year. We took all patients with the diagnosis of sarcoma that were undergoing surgery, and we took a piece of their tumor and we put it in mice to see if we could create an individual patient mouse model for that patient, not for the general public, for that patient. And I mean, this is a kind of a cartoon of how it works. We took, at the time of surgery, literally on the back table, I took a piece of the tumor, you know, with a pathologist there, so they knew it wasn't a margin. Got a piece of the tumor, and then in conjunction with a professor at UCSD who we've become collaborators with, they have worked out a technique to surgically implant that piece of tumor in the corresponding anatomic location in the mice. Surgical orthotopic implantation is what they call it. Versus the typical mouse model or xenograft, which is just subcutaneous. They stick it underneath. And there's a number of benefits to having the orthotopic. I mean, if you're going to do it, I figured we might as well do the best, right? If we're going to try it. And there's a lot of data showing the orthotopic, if you put it in the same location, it recapitulates the human disease much more accurately than the subcutaneous model, and similarly responds to drugs and like that. So anyway, the kind of intent for me was I just really wanted to see how feasible it was for this patient population. It makes a lot of sense, particularly if you did it relatively early in the course of the disease, so you had time for it to grow. The drugs don't work great for sarcoma patients, and if we could find something better that actually worked on their tumor rather than an idea based on a gene profile, it was appealing. But in the clinic, it's nice, we've done studies in the past where we've taken tumors and grown them in mouse models in the lab. Very ideal circumstances here at UCLA. I want to see if in the clinical setting, how successful it was. And then also get an idea of what group of sarcoma patients that it made the most sense for. In other words, who could we create the model for? So let me just, and then each mouse model, once it's created, a series of drugs are identified that are used to treat the mouse model with, in conjunction with Singh and Chmielowski and some other medical oncologists that are candidates, either that the patient's seen or not seen, mouse tested. And this is just an example. This isn't anything specific. But this is a control, and these don't work very well. These inhibit the tumor. You can use these as a potential for your patient, right? And it's been a very productive. Each mouse model has generated a number of publications, a lot of interest in this. This is the summary data, which is really kind of my intent behind the whole study. So again, 1 year. It was 107 patients with sarcoma. And I included low-grade because I wanted to see if we could create a model for low-grade sarcomas. I mean, there are some low-grade ones that become problems, and I wasn't sure. None of the low-grade tumors we were able to create a successful model for. They just didn't grow. So if you have a low-grade sarcoma, don't pay money to have somebody create a mouse model for you. It doesn't work. For the high-grade tumors, obviously that's the group that's the most interest. That's the group that's the chemotherapy question is in the mix. And as you can see, there was, on the study, there was 15 leiomyosarcoma patients, and it was, again, the third most common. Was it the third? Well, second most common histology. So, right where it usually is. So what we did is looked at the factors that were associated with successfully producing a model for a patient. And now each one of these models is being treated, and the patient impact is being done. But this study just closed. So this is summary data. So what are the factors that predict the ability to create a successful mouse model? And there were, as we said, there was 15 leiomyosarcoma patients. There were 8 successful mouse models treated for leiomyosarcoma patients. PDOXs, or whatever you want to define them. And really, great, you know, they were all high grade, so it didn't matter. But site, primary metastasis, gender, none of that mattered. Really, the only thing that mattered was whether you got preoperative, so right before I did surgery on you, whether you got radiation or chemotherapy right prior to surgery. So the overall success rate in an untreated high-grade sarcoma in this initial pass-through was 62%. Now, it was a little higher, but in that range, 60 to 70%. chance of an untreated high-grade sarcoma creating a mouse model for you. If you got preoperative radiation therapy, the success rate was basically 0, 14%. So if you've got a sarcoma and you want to create a model, you should get a piece of tissue before you get radiation, because after you get radiation, it's not going to grow. And then preoperative chemotherapy did decrease the risk of it, but on multivariate analysis, it didn't remain significant. So it decreased it somewhat, but it didn't eliminate it. So the best, in terms of creating the mouse model, is to get the tissue prior to getting any therapy, or immediately prior to getting the tissue. But the idea is the median interval to creation of the model from surgery was actually 4 months. And then the patients are treated with the drugs. Information is obtained. And then, if needed, it can help the physician guide the further therapy. Now, this is experimental. It's not standard of care, obviously. But that question of whether the drug works or not, this is hard data on their tumor, your individual tumor. There are companies out there that do. There's one that's well known. It's called Champions. So this is part of that personalized medicine deal. You can profile your tumor, get ideas of work, but at the end of the day, you're still the person where they have to test it in. It'd be nice to have a model of your tumor. The reason it hasn't really been done in the past is that it's expensive and it's a cumbersome process. But I think that the realization that we can individualize it for each patient it's starting to become a reality, and it's definitely out there. So it's something to become aware of. And as we get the outcome predictions from these patients, we'll start writing that, which is really the main question. Did we impact the outcome of these patients based on this data? And I don't know the answer to that yet. They're all being followed. But I know who I can create a model in and who I can't. So on that, I'll finish and open the floor to any questions.
Process on percutaneous biopsies?
Yes. In fact, that's probably really the best. I mean, if I had to do it again, you don't want to delay anybody's therapy, right? Is you do the core. They take about a whole bunch of cores, but you take one of those, and that's where you grow the PDUX in. And the best scenario would be to do it in the setting of the primary tumor. I know there's this thing where the metastasis is different, but if you model that out early, median interval to recurrence or development metastasis is, depending on the situation, about 1.5 to 2 years for sarcoma patients. So it's a nice window. You can get standard therapy. You can even test in the model, when we've done this, whether the standard drugs we gave the patient worked. And we've shown in certain patients that it didn't. And that correlated clinically. We have those clinical correlates, but yes, we can. Yes?
What if, when we are creating a model, what if patient's tumor or patient's cancer is progressing differently than the one in the mouse?
Then I wouldn't use the data.
Is it being tracked that how the patient's cancer is progressing and how the mouse is data?
It's not, simultaneously. I guess we'll get more data on that. What has been shown is, the problem with most of the xenograft models is they're subcutaneous and they don't metastasize. So there's an argument, does it really recapitulate the disease in humans? The orthotopic aspect kind of eliminates that because they can metastasize, like in the human patient, and the response profile is there. Do they progress the same in each? I can't answer that question.
There's a clinical trial that Champions Oncology was trying to do, try to answer this question, take a tumor, put it in the mouse, and see what happens to the patient at the same time, treat them simultaneously. was a very cumbersome and very difficult trial to do for the logistic reasons. It takes a few months for these things to get established. So you can't quite correlate it exactly, and they eventually scrapped it.
Because I would assume that physical and environmental factors will also affect the progress.
At the end of the day, you should look at it as that's a model. That's probably the closest model you can get for testing any drug in humans. And there's always going to be inherent problems with
Yeah, exactly. I mean, look, basically, I mean, if a drug's coming down the pike, and the drug companies can talk about this, the last step that's done before it's taken to clinical trial is, does it work in human tumors in mice? And if it does, that's sufficient preclinical evidence to justify a clinical trial. It's never been individualized, though, right? I mean, it just hasn't been. It's for broad classes. And the question is, can you individualize it? And for some diseases, I don't think it's worth it. Some diseases, I don't think you can. But for sarcoma, it makes a lot of sense. It's a high recurrence risk. The drugs don't work very well. I mean, it just fits well for a number of reasons. There's a lot of tumor at the time I take it out. They're big tumors. It's not like if I take a piece of it, it's going to compromise anything. So almost every reason it fits so well for this disease. And the question was, is it feasible? I mean, this was in the clinical setting. I mean, this wasn't in the lab where I ran across this. This was the actual. This was real time, real life. So, I mean, it's interesting, and it is experimental, and it's not 100%, but it's at least answer that question of. I get frustrated when you get these profiles, and everybody gives you all these different things that may or may not work, and it's like, well, geez, I mean, I don't have the time, or nor do my patients to do that, and who am I going to test it in? It's me or my patient. I mean, it's my patient. It's not fair. So there has to be a better system for that.
Actually, two quick questions. My leiomyosarcoma was originally diagnosed as a lipoma, and a biopsy was done, and then lipoma turned into leiomyo, or was I just misdiagnosed?
Well, I mean, they diagnosed you clinically, right? They just said you had it.
Needle biopsy.
They said it was a lipoma.
Originally, they said it was a lipoma.
Either they missed the tumor, but no. Lipomas don't change into leiomyosarcomas. So, I mean, my take on that would be they just missed it when they did the biopsy because fat looks like a lipoma, right?
Secondary causation of sarcomas. Do you have any idea what on
I mean, Arun and Bartos can talk about this, but basically the way that I think about it, I think of sarcomas as the error rate of genes. It's a random event. It's not anything you did or didn't do. That's why in kids, they're the third or fourth most common solid tumor in children. Actually, sarcomas are. But, they don't smoke or drink or in the sun and stuff like that. But their genes make errors, and that rate is constant over time. But as you get older, people are exposed to the sun and all this stuff, so the other malignancies jump up in the prevalence. And sarcomas, although that error rate stays basically the same, the percentage that they make up of the overall cancer population drops much significantly. And it's not so much that it changes over time, it's more that the other ones jump up in prevalence. So most sarcomas are driven, there's an event that we can identify, whether inhibiting it in and of itself, like in GIST, where you give it Gleevec and you can block the c-KIT, whether that's enough, and other ones is not. So Ewing's has a specific translocation, synovial has a specific translocation. There is a group of them that have a more complex, like leiomyosarcoma makeup, so it's unclear. But I would be surprised if there's not some sort of event that has yet to be identified. So for most sarcomas, there's, I don't know, Arun or is Bartos here? You guys can come in.
Previously been exposed to radiation.
Right.
Women who've had breast cancer and treated with radiation. It's one people who have inherent predisposition syndromes, who have genetic deficiency syndromes, some people like Leukemia.
Those are extremely rare.
Those are rare.
What are the odds of friends getting leiomyosarcoma? My friend and I both have it, and we both worked on cruise ships around South America 2 months at a time. So
Very-
we just think it's kind of unusual.
That's unusual. I mean, I don't know of any correlate. The only other environmental thing that I'm aware of is Agent Orange. There's been a weak association, but even that's kind of iffy. So there's not anything specific that some environmental factor that I can hang my hat on. Other than what Dr. Singh talked about radiation, there is definitely a radiation-associated sarcoma.
Were you asking whether or not a previous tumor from years ago could be biopsy?
No, I meant,
Oh.
ahead of pre-op, when you're doing the initial evaluation, could you do, instead of doing it in surgery, could you do the biopsy ahead of time? That's what we're recommending,
Okay.
you do at the same time to the mouse.
All right, then I have a question. If you have an older tumor that's been removed, can you have your own mouse? Did you?
No,
I asked you to have your own mouse. No, it has to be done.
it has to be done on fresh tissue. Yeah, you know, I mean, I can tell you what the success rate is from the time of surgery, the likelihood of creating a mouse model. We have the data, 62%. I mean, I can tell you. From the core biopsy, I don't know exactly what it's going to be, but it'll probably be a little lower, but they can do it. The core is a fair amount of tissue. You definitely need fresh tissue, though. You can't do it off something that was done before. Yeah, but I mean, look, in a perfect world, it'd be nice to have in the bank. Yes, I have a model of my tumor, and that model can be shipped to whomever you want. They have the XYZ thing, they're convinced it's going to work. Okay, prove it to me on my tumor. But, you know, I don't know. It's the future, or maybe not. I don't know. But it's an interesting concept.
And LMS, metastatic lesion to be successfully resection via laparoscopy?
Sure. I mean, anything can be taken out by laparoscopy. It's really not an ideal way to take care of sarcomas. In fact, in retroperitoneal sarcomas, it's contraindicated, certainly for primary disease. I don't know if anybody's really looked at that. If it's clinically indicated and it's a metastatic lesion, then and they can do it safely, then I guess it's safe. The problem with laparoscopy, though, I mean, sarcomas are big. I mean, even metastases are relatively big. What they do is they drag it through small holes. I mean, they put it in a bag and this, that, or the other thing, but it's just not a very amenable tumor to laparoscopic surgery, really. I mean, and the other thing that can happen, and certainly, and I see, you can, if you look, the tumor can rupture a lot more easily if you're doing it. Well, the manipulations with instrument, you don't feel it, right? And it just can convert somebody, certainly with primary disease, into an incurable situation. That could easily have been fixed if they just had proper surgery. And the whole, that's just a scar question, right? I mean, they don't still want to have a bigger scar. I mean, to me, I don't quite get that, so.